Hi, I'm going to introduce myself as Vimal Ravi. I happen to be one of the critical care medicine specialists and pulmonologists. I work in Springfield, Missouri, and I happen to be one of the staff members at the University of Missouri. The reason behind me making these videos is that ever since the COVID-19 pandemic started, you have information overload. There are papers coming out every day, and there's so much material available online that very often one doesn't know what to look for and how to sift through all that data and make sense of it. And ultimately, so much information sometimes becomes counterproductive. So the only aim behind me making these videos is to summarize information, summarize trials, and sort of go through a large volume of data in a small amount of time so that people who are time constrained can just watch these videos and get any sense of the useful information out there. Obviously, it's not possible for me to quote specific papers or I might be quoting specific trials at certain points of time during the lecture, but it's possible that I don't give credit to a certain author, but that's purely in the best interest of time and to make the video as short as possible. So the first video is going to be more of a generalized video where I try to go through most of the common concepts in the treatment of this disease. I'm going to be focusing on hospitalized individuals, particularly those in the ICU, because that's what I deal with and have dealt with during the past 1 year or so, ever since the pandemic started. Specific issues with regard to management, as in like how do you anticoagulate someone, or how do you deal with cardiac complications, renal complications, specific drugs, I'll be going into in subsequent videos. So the purpose of this video is to give you an overview of how do you manage a COVID-19 patient in the hospital. So there are a bunch of institutional protocols out there. Most of them have been derived from guidelines which have been issued by different societies, by the National Institute of Health, by the Infectious Disease Society, the Society for Critical Care Medicine, and so on. But if you look at most protocols, most of them are pretty... They've got a lot in common, and that's what I'm going to be trying to focus on. So when the patient first comes in with a diagnosis of COVID-19 into the hospital, the first thing we check is a CVC with a differential. We tend to focus on the total lymphocyte count trend. We check a complete metabolic panel. You check a creatinine kinase, and you check a C-reactive protein. Every other day or so in the ICU, we tend to check coagulation parameters like a PT, PTT, fibrinogen, D-dimer. And at baseline, you check an LDH, you check a troponin, and you should have one EKG. And if you do end up starting a QTC prolonging agent, it's advisable to repeat the EKG. We also do check for hepatitis serologies, simply because some of these medications and your interpretation of transaminase values might be determined by the presence or not of these particular infections. We do get a chest x-ray. Now, should you get a chest CT on a routine basis or not? If you look at the American College of Radiology recommendations, then a chest CT is usually reserved for circumstances that might change clinical management. For example, that you're transporting a patient and you have infection control issues, and so on, and or to determine disease severity. That's probably when you should be getting a chest CT, because if you look at a chest CT of COVID-19, you can't really distinguish it from other causes of viral pneumonia. Now, should you get a routine echo on everybody with COVID-19? No, simply because you'd have to judge clinically if you have too much hemodynamic compromise, or if you have a troponin value which goes through the roof, knowing well that acute myocardial injury is a complication of COVID-19, then those are the circumstances in which you would get an echocardiogram. I don't believe that you need to order a routine echocardiogram for every single patient. Having said that, you do have your bedside ultrasound and a quick look at the heart. I do it, and I do recommend doing it. The other thing is secondary bacterial infection. How do you know that somebody with COVID-19 pneumonia doesn't have a routine bacterial pneumonia? Now, if you do suspect this based on chest imaging, or if a patient whom you think has been doing well with COVID but starts to deteriorate, then you should probably suspect a secondary bacterial pneumonia, in which case you would check 2 sets of blood cultures and a sputum gram stain and culture. It's probably worth checking a procalcitonin also. However, I'd have to make the caveat that procalcitonin levels have been known to be elevated as COVID-19 progresses, even without superimposed bacterial infection. So, the utility may not be as much as you'd generally presume. Now, coming to management issues. Should you be treating empiric bacterial pneumonia in all these patients? The general recommendation is not to administer empiric therapy for bacterial pneumonia. There's limited data, but it is, if you look at all the case reports and all the studies, bacterial superinfection is not a prominent feature of COVID-19. Now, again, as I said, as you're treating the patient, if your patient has defervescence and then develops a new fever, or he develops new consolidation on chest imaging, then it does make sense to order a blood and a sputum culture and treat empirically for bacterial pneumonia. Again, a low procalcitonin level is going to help you rule it out. And as I said before, if you have a higher procalcitonin level, then it doesn't necessarily mean a bacterial infection, and you'd have to use your clinical judgment there. The next thing I'd want to talk about is prevention of venous thromboembolism. Now, most expert panels, most societies will say that you do need pharmacological prophylaxis for venous thromboembolism in a hospitalized patient with COVID-19. I chose those words carefully. I said hospitalized patient with COVID-19. And this is particularly so in those who are critically ill and in the ICU. I'm going to make a separate video on hypercoagulability in COVID-19 because this is an extensive topic and requires some amount of deliberation. What I would like to comment in this video is the fact that initially when the pandemic started and early last year, you had something like 20 to 40% incidence of thromboembolism and pulmonary embolism in these patients, and subsequently, since people became well aware of what was going on, everybody started getting anticoagulated, and so the incidence actually came down, and so the recommendations as to the dose of thromboembolic prophylaxis that you need to give changed, and that's why I'll be making a separate video on this. The other thing that is important is to avoid nebulized medications. So if you're giving an inhaled medication, you're better off doing it with a meter dose inhaler rather than with a nebulizer, so that you avoid the risk of aerosolization. Now, in terms of COVID-specific therapy, the first thing I'm going to address are the glucocorticoids, specifically dexamethasone. Why dexamethasone? Because that was the drug that was studied during the major trials, and so that's what the data is on. But having said that, the dose recommended of dexamethasone is 6 milligrams daily for 10 days or until discharge, whichever is shorter, and that is for severely ill patients with COVID-19. I'm going to talk about approach to disease severity after addressing these medications, because ultimately everything depends on severe disease versus non-severe disease. I'm going to avoid talking about mild, moderate, severe, because it doesn't really change your decision-making algorithm. But classifying this into severe versus non-severe does make sense to me. So when we're saying dexamethasone, obviously other glucocorticoids at equivalent doses, that would mean for 6 milligram dexamethasone, that would be something like 32 milligrams of methylprednisolone or 150 milligrams of hydrocortisone or 40 milligrams of prednisone. So the data supporting these other medications with equivalent doses is much more limited. The trial was with dexamethasone. I'd suggest to use dexamethasone. But if you don't have it, using any of these other alternatives should be good enough. Now, what's the data on dexamethasone? So the biggest trial was the one in the UK, where they looked at approximately 4,000 patients, and they were randomly assigned to either receive dexamethasone or usual care, and there was a reduction in 28-day mortality with dexamethasone. So if you ask me what is the most important medication to treat severe COVID-19, it will be dexamethasone, because overall they had something like a 17% relative reduction. That is between 22.9% versus 25.7%, if I remember correctly. And for patients on invasive mechanical ventilation or ECMO, that was 36% relative reduction. For patients on non-invasive oxygen therapy, it was 18% relative risk reduction. So obviously, that's pretty strong evidence, if you ask me. So glucocorticoids are the most important drug. The good thing about this is that even for developing countries, dexamethasone is pretty cheap, pretty easily available, and I don't think there is a shortage of dexamethasone that I've read reported, even in the new wave, which is going on in India right now. So that's the good thing. So of all the drugs, the most important drug is dexamethasone, and that appears to be cheap, readily available, and to be very honest, that's the drug with the most robust data. And so the other drugs that I'm going to be talking about, the data, as you're going to realize when I quote some numbers, is that the data is much more skeptical. And so if you have dexamethasone on board on your treatment list, you're pretty much covered. Now the other drug for which there's a lot of buzz is remdesivir. Remdesivir, as you all know, it's a novel nucleotide analog, and it has been proven that it's got in vitro activity against SARS coronavirus 2, which is the virus causing this disease. So now, should you be using it as monotherapy? Well, the recommendation right now is if you have severe COVID-19, then remdesivir for a hospitalized patient does reduce the time to recovery. Reducing time to recovery is regarded as a clinical benefit. So in patients with severe disease, remdesivir is probably best off for people with low flow supplemental oxygen, because that's the population in which it has best effect. But the optimal role of remdesivir is pretty uncertain. So you have it's almost a tale of two conflicting trials. So if you look at the WHO trial, they actually suggested not using it in a hospitalized patient because there was no clear evidence that it improved an outcome which was important for the patient, like mortality, like the need for mechanical ventilation. But if you look at the NIH guidelines or the IDSA guidelines, that is the Infectious Disease Society of North America, they do still recommend using remdesivir in a hospitalized patient requiring supplemental oxygen. And there are reasons for this, simply because there's a trial known as an ACTT1 trial, where this is a multinational randomized controlled trial where they give remdesivir for up to 10 days, and it's included something like 1,062 patients or so. And remdesivir did result in a faster time to recovery, and they defined this as discharge from the hospital or being hospitalized without the need for continued oxygen. But in contrast, if you look at the WHO-sponsored Solidarity trial, there was no difference in overall 28-day mortality, and they looked at something like 2,700 odd patients. and that's the reason behind the WHO recommendation. So it's basically the difference between these two trials. So there's a mad scramble right now, especially with the newer wave in India and the subcontinent, and they're talking about not having enough remdesivir. Well, to be honest, if you look at the WHO trial, remdesivir is not a miracle drug. Let me put it that way. So, and the other thing is, should you give 10 days of remdesivir or should you give 5 days? There was not much difference between trials which evaluated 10 days versus 5 days. Then, what about non-severe COVID-19? And again, I'm gonna later in the video, I'm gonna go into what constitutes severe COVID-19 and what is non-severe COVID-19. So, in hospitalized patients with non-severe disease, remdesivir may have modest benefit, but again, the clinical significance is uncertain. So again, in the ACTT1 study where they gave 10 days of remdesivir, it did not appear to reduce time to recover among the 119 patients or so with mild to moderate disease. But that particular subgroup was underpowered to report to study that particular effect. The question is, should you be using baricitinib or not? Baricitinib is a Janus kinase inhibitor, initially used for the treatment of rheumatoid arthritis. And in the US, the FDA gave an emergency authorization for using baricitinib 4 milligrams orally once daily for up to 14 days to be used in combination with remdesivir in a patient with COVID-19 who required oxygen or required mechanical ventilation. Again, although adding baricitinib to remdesivir did improve the time to recovery, there is greater evidence of benefit with dexamethasone in this population. So again, this is why I keep harping back to the dexamethasone and the steroid. Baricitinib, I'm not aware of it being available in some of the other countries, and frankly speaking, again, if you're using your steroid, I think you're on the right track. Coming to the big elephant in the room, that is tocilizumab, which is the interleukin-6 pathway inhibitor. What's the rationale behind trying to calm the inflammatory soup, as they say, is because tocilizumab was the first IL-6 inhibitor studied. They've also looked at sarilumab and ciltuximab, and the recommendation right now is to use tocilizumab 8 mg per kg as a single dose for individuals who require high flow oxygen or more intensive respiratory support, as long as it is somewhere between 24 to 48 hours of admission to an ICU. You could also look at it on a case-to-case basis for people who are on low-flow oxygen supplementation, progressing towards high flow despite initiation of dexamethasone, and have significantly elevated inflammatory markers. When I say significantly elevated, I mean a CRP level more than equal to 75. So these are the situations in which tocilizumab is given. And again, in our institution, we limit it to a single dose and in patients who are already receiving tocilizumab. When should you not give tocilizumab? The recommendations are if your platelet count is less than 50,000 or your serum alanine aminotransferase is more than 5 times the upper limit of normal, or if there's an elevated risk of a GI perforation or your absolute neutrophil count is less than 500, you'd want to avoid this medication. The thing, since we're talking about cytokine storms, so there are 2 big studies here. One is called the REMCAP study, and then the recovery study, which actually had better results than what some of the earlier studies showed, and that's why it's almost like we've gone a full circle with this anti-cytokine therapy. From a rationale perspective, it makes a lot of sense because you have a cytokine storm, and a single-pronged strategy may not be good enough. So the important thing to note is that in the REMCAP study, something like 88% patients and roughly 82% in the recovery trial receiving combination therapy with corticosteroids, mind you, it did improve 28-day mortality in the recovery trial confined to the subgroup of patients who are also receiving steroids. So I keep coming back to steroids. Steroids is the most important thing. So ultimately, there's another study called the COVACTA trial, which is basically a double-blind randomized control trial where they did not see any change in clinical status or 28-day mortality when they used tocilizumab. The difference is that was a traditional randomized control trial, while the REMCAP and recovery trials are more like an adaptive design where it's sort of a head-to-head randomized control trial. And so when you get a favorable result with a study which uses an adaptive design, you got to view it with a little bit of skepticism, because the design of the study itself is done in such a way that they tend to be more complex to interpret. Let me put it that way. So, but definitely the focus has shifted back to calming the inflammatory soup with these two REMCAP and recovery trials. So the jury is still out on these two particular studies. Then coming to convalescent plasma. So there was a lot of hope with plasma earlier, and obviously convalescent plasma is obtained from individuals who have recovered from COVID-19 and were supposed to provide an antibody-based immunity. And they thought that neutralizing antibodies, being the main active component, was hypothesized to have a clinical benefit when you give it early in the course of the disease, and FDA authorization was given for this, and we did use this quite extensively. But unfortunately, it's well tolerated. That's the good thing about plasma. So there are some adverse effects which I'm not going to get into right now, but by and large, convalescent plasma was well tolerated, but right now there's most of the trials didn't show too much benefit. So outside of a clinical trial, there's not much rationale for using plasma now. Again, I bring out plasma because I keep seeing, the praise for getting plasma in the developing world, and frankly, the evidence is not just there. And now moving to monoclonal antibodies, which try to neutralize the virus by targeting the spike protein and preventing viral cell entry. Those trials are ongoing. In outpatients in the United States with mild to moderate COVID-19, I'm not going to get into that aspect of things because this particular lecture focuses on hospitalized individuals with severe COVID-19. So that's there. Hydroxychloroquine, no evidence. Do not use it. Interferons, again, insufficient clinical data. What about IL-1 inhibitors like anakinra? Again, not enough evidence. Azithromycin, not recommended. Ivermectin was studied. I think there was a retrospective review of 280 patients or so. And again, very low quality evidence, not recommended right now. Vitamin D supplementation, although you should probably, if your patient is deficient in vitamin D, it does make sense to replenish the deficiency. But beyond the recommended upper level of intake, there's no clear evidence that vitamin D supplementation improves COVID-19 outcomes in any way, shape, or form. So coming to the most important thing, which is how do you define disease severity? Because at every point I was talking about severe disease and non-severe disease. So the way you make that distinction is mild disease, you have fever, malaise, cough, most of the URTI symptoms, but in the absence of dyspnea. So it's when the patient develops dyspnea that you think they have at least, so if you want to call something moderate, it would be a patient with dyspnea. And once he gets dyspnea, you start thinking about whether he's going into severe disease, because If he's hypoxic for the purpose of COVID-19, you define that as a room air oxygen saturation less than equal to 94%. So you have a pulse ox. If your saturation is less than equal to 94%, you're hypoxic, and so you have severe disease. Or, of course, if you need oxygen supplementation or you go on a ventilator, that becomes severe disease. The other thing is if you have more than 50% involvement of your lung parenchyma on chest imaging, you'd almost always be hypoxic, and so you'd have tachypnea, you'd have some form of respiratory distress, and so you would call that severe disease. The other thing is with dark-skinned individuals and how whether a pulse oximeter might overestimate the saturation. I'm going to cover that topic separately because I think it deserves a lot of attention, especially in the developing world and with African American population in the United States. So I'll go into that separately. But for non-severe disease, the recommendation right now is supportive care only, close monitoring, monitor for clinical worsening, monitor for hypoxia, monitor for increasing oxygen requirement, and that's all that you do. So basically the definition of severity is if you're hypoxic. And if you're hypoxic, you can further grade that into you're hypoxic, but you're not requiring oxygen, or you're requiring low flow supplemental oxygen, or you're requiring high flow supplemental oxygen with or without non-invasive ventilation. So if you're hypoxic, but you don't have oxygen requirement, the recommendation is to use remdesivir, but you don't necessarily have to use dexamethasone or tocilizumab. If you are receiving low flow supplemental oxygen, then you're better off with remdesivir and dexamethasone. And once your oxygen requirements increase, on a case-to-case basis, you may want to add tocilizumab. Again, if you're on high flow oxygen or non-invasive ventilation, then the best thing would be to take low-dose dexamethasone. Within 24 to 48 hours of admission, then you add tocilizumab as well. So that's a summary of most of the available evidence for COVID-19. There are lots of additional topics that we could go into, and I'm going to make separate videos for the same. Thank you very much.